In the second part of Module 3, we will investigate hemostasis, another important function of our blood and its cargo. This section looks at hemostasis, which is the process of keeping blood in its liquid state while simultaneously preventing excess bleeding. There are some multimedia units in this module, and I encourage you to take the time to review these. Take a few minutes now to review the learning objectives for this module, paying special attention to terms that are used throughout the lesson. If we were to view hemostasis in a simple cascade model, we would see that it occurs in 3 phases. Primary hemostasis involves the platelets and blood vessels and the formation of a platelet plug. So any sort of diagnostic testing related to primary hemostasis involves looking at platelets and blood vessels. We did learn about platelets in part 1 of this module. Platelets are cell fragments. We count them in the hundreds of thousands, approximately 150 to 400,000 platelets per microliter is the normal range. Defects or deficiencies in primary hemostasis are seen as bleeding under the skin or in the mucous membranes, and very low quantities of platelets can result in spontaneous bleeding. Blood vessel disorders are fairly rare, and although they contribute to disorders in primary hemostasis, we will not be reviewing them in this module. Secondary hemostasis then involves the circulating coagulation factors. These are plasma proteins, and they're always circulating, ready to become activated. The picture on this slide represents an electron photomicrograph of blood clot. The stringy material that you see is fibrin, and blood cells are caught in the fibrin web as they travel past a forming blood clot. Pause the playback and click on the picture for a video demonstration of how a blood clot forms. We spoke previously of defects in primary hemostasis, and as being demonstrated in mucous membrane bleeding, nosebleeds, and bruises, or purpura. Purpura are scientifically classified as bruises. What we see in primary hemostasis defects are immediate bleeding, and again, bleeding in the skin, the nose, the mouth, or the mucous membranes. Secondary hemostasis involves the blood clotting or coagulation factors. And what we see is deep bleeding, bleeding into the joints, the muscles, body cavities. And what you see here is an example of what we would call swelling knee or a swollen knee, or heme arthrosis. So bleeding into the joints. It's interesting to know that aspirin ingestion interferes with the ability of platelets to form a blood clot. Aspirin belongs to a class of medications called nonsteroidal anti-inflammatory drugs, or NSAIDs. Other examples of these are ibuprofen and naproxen. They're widely used for treating fever, pain, and inflammatory conditions. Aspirin chemically is known as acetylsalicylic acid and is often abbreviated as ASA. Aspirin has an important effect on platelets. This antiplatelet effect is used to prevent blood clot formation inside the arteries, particularly in individuals who have atherosclerosis or narrowing of blood vessels, or otherwise prone to developing blood clots in their arteries. So these would be people who have had heart attacks, strokes, or people who have had procedures related to their coronary blood arteries. What happens is that the aspirin interferes with platelet aggregation and they can't stick together. If the platelets can't stick together, they can't form a blood clot. This is an irreversible effect. It can take 7 to 10 days to completely replace platelets. And too much aspirin could result in prolonged bleeding. So the point here is it's very important to know the history of the patient when evaluating platelet function tests, since aspirin can be given intentionally to prevent platelet aggregation and may be taken by an individual for some other reason that may impact platelet aggregation. This is a graphical representation called the coagulation cascade. We've seen it previously in this lesson, and it represents the coagulation factors or plasma proteins involved in secondary hemostasis, and depicts how they interact one after the other from top to bottom to end up with a fibrin clot. The study of hemostasis and secondary hemostasis is quite complex. For our purpose, we need to know that each factor needs to be present, that each factor needs to be acting appropriately, so effective, and that in anything that interferes with any of the factors in this cascade from top to bottom will ultimately impact the ability of a fibrin clot to form, and an individual may suffer from bleeding. Remember, secondary hemostasis defects result in deep bleeding, bleeding into body cavities and joints. Additionally, we might have defects that result in too much clotting. Those anticoagulant factors are not represented on the clotting cascade and are relatively new to us in our understanding of hemostasis. So we look for too much bleeding, or people who are at risk for too much bleeding, by screening primary hemostasis, so that's the platelet count, the prothrombin time, or PT, activated partial thromboplastin time, or APTT, and platelet function tests. Too much clotting is a different problem, equally important, if not more so. So medical imaging is important in screening for too much clotting because we're looking for actual presence of clots in blood vessels, or with plasma tests that measure defective anti-clotting proteins. So just like we have proteins that circulate to create clots, we have proteins that circulate to impede clotting, and these are protein C, activated protein C, and factor V Leiden mutations. We also introduced the concept of acquired versus inherited disease. So acquired disease is something that happens in relation to medication or some other disorder. So the taking of aspirin could cause an acquired platelet defect, and liver disease, where proteins are manufactured, including coagulation factors, could result in an acquired disorder of secondary hemostasis. Inherited disorders are those you are born with. So an example of this is hemophilia, which is a factor deficiency, and the individuals with inherited disease either don't make enough coagulation factor proteins or they are defective. So in primary hemostasis, we're testing for the quantity of platelets and also how well platelets can stick together to form a blood clot. In tests for secondary hemostasis, we are measuring the activity of the circulating plasma protein coagulation factors. So basically measuring how fast will patient plasma clot. The activated partial thromboplastin time, or APTT, is measured in seconds. So it's a very quick test, mostly used to monitor anticoagulant therapy. When people have surgical procedures or other conditions that may cause them to clot, to have their blood clot, or when they're being treated for an existing blood clot, they'll be treated with a drug called an anticoagulant. So it does exactly what it says, prevents coagulation. The most common IV or intravenous anticoagulant is heparin. Heparin is usually only given in an acute care hospital setting and is a first line of treatment for those who are at risk of developing a clot. So the activated partial thromboplastin time, APTT, should be increased in time, longer, seconds, when a person is receiving anticoagulant therapy. And we use this test to monitor the effectiveness of the dose of heparin. If people have other abnormalities that impact their circulating coagulation factors, such as hemophilia, which is a factor VIII deficiency, liver disease, which impacts the ability of the liver to produce all plasma proteins, and of course anticoagulant therapy, you will see elevations or lengthening of the seconds used to count the APTT. So the length of time for the blood to clot is increased. We also have the partial thromboplastin time, or PT test. You might have noticed in the coagulation cascade picture that there were two branches ending in a common branch. The prothrombin time test measures different coagulation factors than the APTT. It's also measured in seconds, and it's also used to monitor an anticoagulant. The anticoagulant measured by the prothrombin time is Coumadin. Coumadin is a very common anticoagulant. I would guess that just about everyone knows somebody who's on Coumadin. They might call it a blood thinner. Coumadin is taken long-term and in an outpatient setting, and it's actually related to rat poison. And warfarin, the name given to this rat poison, or the general term for Coumadin, was actually discovered at the Wisconsin Alumni Research Foundation at the University of Wisconsin-Madison, and it was first identified in the 1950s, not that long ago, when farmers noticed that their This is a summary of the major tests used to screen for excess bleeding. The prothrombin time, standardized with the INR calculation used to monitor Coumadin therapy, can be prolonged. So the number of seconds you determine for blood to clot is increased. Prolonged in liver disease, inherited factor deficiencies, vitamin K deficiencies. Prothrombin time measures coagulation factors that are linked to vitamin K. This is a screening test with a low positive predictive value in an asymptomatic population. What does that mean? That means that for people without medication history or symptomatic history, an abnormal prothrombin time probably does not point to a coagulation factor disorder in a person who is just being screened. Meaning, we have to look further. If somebody has an abnormal prothrombin time and nothing else contributing to that abnormality. The activated partial thromboplastin time, just to review, is used to monitor drug therapy. In this case, heparin can be abnormal in liver disease again, abnormal in inherited factor deficiencies such as hemophilia, and is also a screening test with low positive predictive value in the asymptomatic population. What we should take away from this is these are good tests when used for a specific purpose, not very good tests if we're using them to screen people who may be pre-surgical or something else. It doesn't tell us very much, and so we don't do them very often for that purpose anymore. We also have specific clotting factor assays. So the prothrombin time and APTT are what we call global tests. They measure multiple factors at the same time. The clotting factor assays are used to follow up on abnormal global tests, so prothrombin time or APTT. In this case, we're doing testing to monitor the activity of specific factors. This is a specific test, and it has a very high positive predictive value. So in other words, if this test is abnormal, we can feel confident that the individual being tested has an abnormality with a specific clotting factor. You can see these clotting factors are named with Roman numerals, and it's confusing. They were named as they were discovered and not in their order of importance, which is why the coagulation cascade is hard to learn. It doesn't follow in order. Again, the coagulation factor assays measure activity of individual factors versus the global test, prothrombin time, or APTT. Hemophilia is a specific disease representing a deficient factor. In this case, it's factor 8. Hemophilia is diagnosed with the patient history. It's an inherited disease. The increased APTT, so a global test, and a decrease in factor 8 activity. So the specific factor 8 test shows an abnormal amount of factor 8. This is a bleeding disorder with a long history. It was first identified as early as in ancient Egyptian times, and more recently has been linked to the family of Queen Victoria of England and the Russian Revolution. The Tsarina Alexandra, who was a daughter of the queen, was a carrier of the defective gene for hemophilia. She married the Russian Tsar Nicholas, and they had one son, Alexei. So the gene for hemophilia A is X-linked and inherited only by sons from the mother. As this was the only son, the Tsar and Tsarina were very anxious to find a cure for their son, who had, bleeding episodes and many pains, and he was young, and the understanding of coagulation factors at that time was none. There was no understanding. So they came under the influence of a religious charlatan whose name is Rasputin. They believed he could cure their son. The obsession of the royal family with their son's disease caused them to be out of touch with the realities of life in early 20th century Russia. and eventually led to the 1917 Russian Revolution and the rise to power of Lenin and Stalin and communism. So that's a very interesting story for the historians. I've paraphrased it greatly. However, an example of how a disease has influenced history. In the 1980s, this is another example of a disease influencing history. The world was beginning to recognize HIV and AIDS, and the Food and Drug Administration, the FDA, failed to control the spread of the HIV virus through the blood supply. At that time, the only treatment for hemophilia was cryoprecipitate, which is a factor VIII replacement, and it's produced by pooling the plasma of many donors. Since HIV is a blood-borne pathogen, as many as 90% of the diagnosed hemophiliacs of that time became infected. Hemophiliacs now represent 1% of all people with AIDS in the United States, but that equals 4% of people with hemophilia. Another 50%, or about 10,000 people, may be asymptomatic but HIV seropositive. You should know that since this time, cryoprecipitate has been replaced with a recombinant factor VIII, and so the transmission of blood-borne pathogens has been pretty much eliminated for hemophiliacs. Hemophiliacs are also living longer due to more effective treatments, and it could happen that a hemophiliac father could pass his abnormal X gene onto a son. I don't know that this has happened, but hypothetically it could happen. So now we go into a concept of hemostasis gone haywire. This is called disseminated intravascular coagulation, DIC. This is always an acquired disorder, and it follows some underlying disease such as sepsis, so blood infections, obstetrics, cancers. It's a life-threatening condition, and it is essentially the failure of the hemostatic mechanism. We call it hyperfibrinolytic. So if we know that fibrinolysis is the process whereby blood clots are broken down, so there aren't too many, a hyper situation of that would mean that too many blood clots are broken down. So essentially what happens is the body is trying to produce blood clots in response to some condition, and while the body is trying to produce blood clots, they're being rapidly destroyed. So it's a constant vicious cycle of trying to produce blood clots, the blood clots being destroyed, blood clotting factors and platelets are used up, and the patient is bleeding to death. How do we diagnose DIC? So history, remember it's acquired from something related to something else. Symptoms, so strange bleeding, bleeding from incisions, unusual bleeding from body cavities. The platelet count will be decreased, platelets are being used up. The APTT will be increased, coagulation factors are being used up. Fibrinogen will be decreased, a coagulation factor, it's being used up. And then we also see an increase in something called fibrin split products. So this is a hyperfibrinolytic disorder. Blood clots are being rapidly destroyed. The byproducts of that clot lysis are fibrin split products. Everybody always has some because your body is always adjusting, bleeding, and clotting. However, when we start to be able to measure these, so the amount increases beyond a certain low level, we can start to suspect DIC. And of course, all of the other things will play into that, including history, symptoms, and so forth. You should recognize DIC as pretty much a complete failure of the coagulation process and a very life-threatening disorder. Let's move now to the concept of thrombosis. So thrombosis is the idea of too many blood clots or the tendency to form blood clots. This is more common than bleeding disorders. So what we say is an individual has a hereditary deficiency or a hypercoagulability. Remember from an earlier slide, we talked about the anticoagulation, circulating blood factors. So when those aren't working properly or they're deficient, an individual has a tendency to form blood clots. It could also be an acquired condition due to lifestyle. So lifestyle examples would be overweight, sedentary, cigarette smoking, and some other factors that contribute to a tendency to form blood clots. There are two terms related to this, DVT, which is a deep vein thrombosis, and a PE, or a pulmonary embolism. A pulmonary embolism is a deep vein thrombosis that has traveled to the lungs, and it is a life-threatening condition. Diagnosis of thrombosis includes history, sonogram, arteriograms, and venograms, so diagnostic imaging tests. A D-dimer test is a test for fibrin split products, or the byproducts of clotting. So if there is a blood clot, the body will be trying to remove that clot, and the D-dimers, those byproducts of clotting, should be elevated. This test has a high negative predictive value. That tells you that if this test is negative, there's a very strong likelihood that the symptoms that the person is experiencing are not related to a blood clot. We can also long-term measure the actual circulating anticoagulants, protein C, protein S, factor V, Leiden. Those are all natural anticoagulants. The graphic, killer legs, is telling us that some people form blood clots in their legs or deep vein thrombosis, either naturally or due to inactivity. And this is a pharmaceutical company that is recommending a treatment for that. A traveling deep vein thrombosis becomes a pulmonary embolism, and it can be rapidly fatal. We sometimes hear about people on long airline flights in fairly cramped spaces and different conditions, dehydration, and so on and so forth. And this is true. So individuals who have a tendency to form blood clots do need to be aware of long periods of inactivity, such as might be experienced on an airplane. And the killer legs graphic is trying to describe that a little bit. Here's a summary of primary and secondary hemostasis, what is happening in these areas and what happens if there's a dysfunction, and the tests used to measure. You should be aware of how the basically 4 or 5 tests that we talked about work, where they work, and the kinds of disorders they can measure, and also the drug therapies that they measure. Thrombophilia, again, the tendency to form blood clots. You should know a little bit about how blood clots or thrombophilia is diagnosed, what a deep vein thrombosis or a pulmonary embolism is, and then you should also understand about disseminated intravascular coagulation and what is essentially happening there. So your next steps will be to complete the quiz for this module and participate in the discussion for this section.